all of us. Please feel free to write down your questions because endocrinology is a branch which often you find very complicated and is often kept for an option. But believe me, the way we will go through the cases now will solve a lot of things which are there in your mind as queries. What I'll be doing today is I'll be mainly focusing on 3 common endocrine problems. First one is disorders of sexual development. Second is congenital adrenal hyperplasia. And third is neonatal hypothyroidism. So because congenital adrenal hyperplasia becomes part of DSD spectrum, I will be including that in the DSD itself. So I'll start now with my first slide. And in that you will see what I'm going to sensitize you is for the recognition of endocrine problems in newborn. See, when you are doing your neonatal term, you quickly realize that almost all disorders present the same way. When you examine the babies, the signs and symptoms are all very similar. So how do you then know that the given baby has an endocrine problem? So there are certain signs and symptoms which are endocrine pointers. And you need to have a high index of suspicion. You need to think in your mind that yes, although in my practice, hypothermia, hypoglycemia, sepsis, inborn errors of metabolism, all are common, it is also likely that this baby may have an endocrine disorder. So first thing that you must have is a high index of clinical suspicion. You need to have a logical approach. You need to have a very good laboratory support, which I understand in many situations may not be immediately available, but most metros and semi-metros do have good laboratories today. So you should have good investigations at hand. And as I said, that there are situations in which your sepsis and an endocrine condition or your inborn error of metabolism and an endocrine condition can coexist. So do not forget that you will have a complex situation where endocrinopathy as well as a common condition may coexist in a newborn. So moving on to the clinical clues in terms of symptoms. Now, for those of you who have been doing some neonatal endocrinology or neonatology for that matter, do realize that vomiting, convulsions, listlessness, apathy, drowsiness are seen in any newborn who is not well. So how do you then decide that this child may have an endocrine condition? If you have a baby who is persistently vomiting and you have largely ruled out other causes such as say sepsis or hypothermia, a neurological condition, then think about congenital adrenal hyperplasia or adrenal hypoplasia. Now see, in endocrinology, hypo and hyper, these terminologies are very commonly used. And be very careful when I say hyper versus hypo. Hypo is underfunctioning, hyper is overfunctioning of that gland. But in case of persistent vomiting, both adrenal hypoplasia as well as congenital adrenal hyperplasia can cause persistent vomiting, weight loss, failure to thrive. Convulsions can be caused by hypocalcemia, hypoglycemia, or electrolyte imbalances such as profound hyponatremia. Now, newborns are resistant to neurological derangement, which is caused by hyponatremia as well as hyperkalemia, but only to a point. Once it reaches a critical point, suddenly the symptoms will develop. Failure to gain weight again can be an adrenal disorder, or you can have isolated growth hormone deficiency or multiple pituitary hormone deficiency. And if you find that a neonate or a slightly older child is hypertensive, then think of adrenal hyperplasia, rare causes, or endocrine tumors. Laboratories are constantly sent from neonatal care units. And it's often that when you look at the laboratory result, you realize that something is amiss, something is not fitting properly in my diagnosis. And then you realize that it could be an endocrine condition. For example, when you send for neonatal screening, you will be surprised to see a high TSH. Often these babies do not show any signs of symptoms at birth. And therefore, every single baby who is born, irrespective of the gestational age, irrespective of the maternal thyroid background, must be screened for hypothyroidism. As I mentioned earlier, you get hyponatremia in adrenal disease, syndrome of inappropriate antidiuretic hormone secretion. You get hyperkalemia, that is high potassium, in adrenal failure, hypoaldosteronism, or type 4 renal tubular acidosis, which, as you may understand, a type of pseudo hypoaldosteronism. So type 4 RTA is pseudo hypoaldosteronism, where there is resistance of the renal tubules to circulating aldosterone. You get hypoglycemia in, again, adrenal disease, congenital adrenal hyperplasia, and there is a whole group of hyperinsulinemia. Today, we are not going to cover hypoglycemia, so I won't get into details of this, but you get this in infants of diabetic mother, Beckwith-Wiedemann syndrome, and congenital hyperinsulinemia. Hypocalcemia is caused by hypoparathyroidism, which can be temporary or permanent, especially when associated with hyperphosphatemia. Metabolic acidosis is seen in adrenal failure, as well as you get it in other disorders such as sepsis and inborn errors. And hyperglycemia, which is persistent, may be seen in neonatal diabetes. See, a lot of us do tend to forget neonatal diabetes as a cause of hyperglycemia because stress hyperglycemia is more common than neonatal diabetes. But don't forget neonatal diabetes. If your patient's blood sugar is not coming down, despite the fact that sepsis and other things improve. Now, these are some of the complexes, I call them symptom signs and complexes, which guide you to the diagnosis of a neonatal endocrine disorders. So if you've got hypoglycemia and your GDR or GIR, glucose infusion rate, is more than 8 milligram per kg, in a large baby with hairy pinna who may or may not have hepatosplenomegaly, think of an hyperinsulinemic condition such as infant of diabetic mother, congenital hyperinsulinism, Beckwith-Wiedemann syndrome, etc. If you have got a complex of hyponatremia, hyperkalemia, metabolic acidosis, and atypical genitalia, you are looking at congenital adrenal hyperplasia. No other condition will have these four components together. Similarly, hypocalcemia, hyperphosphatemia, and cataracts you get in hypoparathyroidism. Hypoglycemia, midline defects such as micropenis, cleft palate, you may have growth or multiple pituitary hormone deficiency. When you have hyponatremia associated with hypokalemia and reduced urine output, you have dilutional hyponatremia, hypokalemia caused by syndromes of inappropriate antidiuretic hormone. When you have a midline cleft, midline defect, polyuria, polydipsia, and hypernatremia, so you have got pure water loss. So you are retaining your sodium, you're becoming dehydrated, you have to suspect diabetes insipidus, or where antidiuretic hormone secretion is less. If you have persistent hyperglycemia, dyslipidemia, growth failure, think of neonatal diabetes mellitus. Now we move on to the three important topics for today. The first one being disorders of sexual development. Now please focus that DSD stands for disorder of sexual development. It does not stand for disorder of sexual determination or anything else. It's development of genitals which is defective. And it's a psychosocial emergency. In fact, it's quite common for a pediatrician to give me a call from the delivery room stating that, please come running now. There is a kid who is born with genitalia, which I can't tell whether it's a boy or a girl. And then it becomes chaos. because parents are standing there asking for only two questions when a baby comes into this world. What is the weight and what is the gender? And in these situations, how to deal with it, we will go on as I move through the slides. So what terminologies you must avoid? Never say about intersex, ambiguous genitalia, or hermaphrodite. These three terminologies you should forget as a trainee pediatrician or a neonatologist. These are extremely difficult for the parent to accept in terms of psychological trauma. So these are very traumatic things to say, that your baby has intersex, or your baby has ambiguous genitalia, or your baby is a hermaphrodite. I think it's awful. It's horrible. Please try and avoid these terminologies. Don't even utter these terms. Similarly, when you're dealing with disorder of sexual development, never ever say he or she. Keep saying your baby, your baby, your baby. Because just by slip of your tongue, you say he, they will hang on to that he forever. So always say your baby, your baby, your baby. As I said, disorder of sexual development by definition is a condition in which the development of chromosomal, gonadal, or anatomical sex is atypical. Now, every time I'm mentioning this, I'm not saying the word ambiguous. Ambiguous is a word which is gone. You call it atypical. So it's atypical genitalia. And in this slide, you will realize that whenever there is a discordance between chromosomal sex, gonadal sex, and anatomical sex, you call it disorder of sexual development. So, for your understanding, sexual determination is largely genetic, where development of bipotential gonad is changed into either a testes or an ovary. Sex differentiation is largely hormone. So when the sex determination, which takes place within first few days, then starts the sexual differentiation, which is under the control of hormones. And it requires the gonad to develop and function appropriately to produce all the peptide hormones as well as the steroid hormones. And sex development is a broad terminology which encompasses all this. So how does normal sexual development take place? Primarily, you have a chromosomal sex, either 46XX or 46XY, or rarely you may have a combination of chromosomes. That gives you a gonadal sex. Then you produce your hormones, your peptides, and your factors, which have endocrine as well as paracrine effects. That leads to development of internal genitals and external genitals. At birth, when a parent or a doctor or a healthcare provider sees the baby, recognizes the genitals as male or female, a sex gets assigned, and then comes the whole huge aspect of gender identity, gender role in the society, sex of rearing, and many psychosocial issues related to that. So development of normal sex is very complex, as you can see, but it starts with chromosomal sex. Now the diagram on the left-hand side of your screen is the testicular development, which is in blue color, and on the right side is the ovarian development. Now, when I was being trained in pediatric endocrinology in early 90s, we were taught that by default you become a female unless maleness is imposed on you. Now that concept had changed over the years, and we now know that although development of a normal male is more complicated in terms of its genes, its ligand, its factors, and its receptors, ovarian development does not occur by default, or just the absence of testicular determining factor or sex determining region of Y does not lead to ovarian development. For normal ovarian development, on your right side, you can see In a pink box, I have shown all the genes. So all the genes are required for normal development of a female gender. Whereas on your left-hand side, you can see that the blue genes which I have seen, SRY, SOX9, PGD2, and FGF9 are male-specific genes, whereas SCF, BMP2488, WNT4, FOXL2, etc. These genes are specific genes necessary for female development. So just because you do not have the factory to become a man, you does not become a woman by default. You also require female-specific genes. One more important concept I want you to understand at this stage is that because your mother, a baby's mother, is going to raise her hormones so high, and they're all female hormones, she is going to bathe the fetus in very high level of estrogen. So your maleness actually occurs a little earlier than femaleness. So if a male baby is developing inside a mother's womb, it actually differentiates faster than that of a female fetus. So that despite maternal high estrogen, the maleness is preserved. So coming back to the clinical picture, when do you suspect disorder of sexual development? When you obviously cannot tell. You look at the genitals and you say, I can't tell whether this is a boy or a girl. But to define it in a more scientific way, apparently female genitalia with enlarged clitoris, posterior labial fusion, or an inguinal mass in a normal looking female genital. Or apparently male genital with undescended testes, micropenis, perineal hypospadias, or unequal rugosity of genital folds. Family history of disorder of sexual development, or any discordance between the genital appearance and prenatal karyotype. Now, this is what the definition encompasses. But in India, since legally we do not get assessment of prenatal karyotype, for all practical purpose in India, the last clause remains only academic. But in the developed part of the world or many other countries where prenatal karyotype is determined, you may get a discordance at birth between the genital appearance and the prenatal karyotype which was assessed. Now in 2006, all the old terminologies which I mentioned, like ambiguity, then intersex, hermaphrodite, were abolished. And we have the new classification which starts from the karyotype. So the paradigm shift in understanding of disorder of sexual development is that the starting point now is your karyotype. And then it becomes simple. You only have three groups: 46XY disorder of sexual development, 46XX disorder of sexual development, and sex chromosome DSD, where you have a mixed karyotype. Now, why did we abolish all this? Because as I said, it's stigmatizing. It's awful for a parent to listen to these terminologies, which we as doctors in United Kingdom used to very commonly discuss in front of parents, and even here in India. And you know, it just used to be so bad. And we never realized it until we were taught not to say this. And importantly, there has been a huge progress in the diagnosis, surgical management, and understanding of the endocrine, genetic, psychosocial, and ethical issues around DSD. So based on this experience of patients, feedback given by patients, and doctors' experience around the world, the new nomenclature came in place in 2006. And this is how it is, primarily three groups. I'll start with the last group, 46XX DSD. So you are a genetic female, and then you have got atypical genitalia. So it can be a disorder of ovarian development where you may have ovo-testicular DSD. You may have 46XX testicular DSD. Now, some of you may be surprised to see this, that how can 46XX develop testes? They may have an SRY, which is sex determining region of Y chromosome, or sometimes even without SRY, if you have got duplication of the SOX gene, with 46XX, you can still develop testes, but they are usually dysgenic testes. They produce some testosterone, virilize a female, but are not good enough to be raised as a male. And of course, you can have gonadal dysgenesis. The second group, 46XX DSD, is androgen excess in a 46XX female. So you have got androgens. They may be coming in the fetal life, where you can have something like congenital adrenal hyperplasia, which is what we will be discussing, as it is the commonest cause of DSD in a female. Then you may have placental aromatase deficiency, or sometimes mom may be treated with medications such as progesterone or medroxyprogesterone, or sometimes she can have disorders such as the luteoma, which produce androgen in excess and lead to virilization. And then there are some syndromes which are associated with 46XX normal female, which we won't be discussing. Then now let us move on to the middle group, the 46XY DSD, so a genetic male with atypical genitalia. This is perhaps the most complicated group that you ever see in DSD. So you have multiple causes of this. You may have complete gonadal dysgenesis. So very early in the development of gonads, something goes wrong, gonads are dysgenic. So it may be complete, it may be partial, or it may be something known as vanishing testes syndrome or testicular regression syndrome, or you may have ovotesticular DSD. The second group within this group of 46XY DSD is disorder in androgen biosynthesis or its action. So you may have a biosynthetic defect such as 17-hydroxysteroid dehydrogenase, 5-alpha reductase, or star mutations. You may have defect in the androgen action. So, okay, you're producing enough androgen or testosterone, but it just doesn't work on your genitals. Why does it happen? For a hormone to act, you need a good receptor. And if the receptor density is low or the receptor is faulty, you may have partial. And if there are no receptors, you may have a complete androgen insensitivity syndrome. So the genitalia there may be partially virilized, or sometimes in complete androgen insensitivity, they're completely normal looking female genitals in a 46XY male. Then luteinizing hormone receptors, which are present on the Leydig cell, which give you testosterone, may be defective. And you can have disorders of the anti-Mullerian hormone or anti-Mullerian hormone receptors. And then there are some other syndromes in which you get severe hypospadias or cloacal atrophy, or epispadias or cloacal extrophy. And the third group, which is the sex chromosome DSD, you have got a mixture of normal and abnormal chromosomes of both genders. So you can have 45X Turner syndrome or 45X, 46XX Turner syndrome mosaic. You can have 47XXY Klinefelter syndrome. You can have 45X, 46XY, what is also known as mixed gonadal dysgenesis. In 2020, that ovotesticular DSD from this classification has been moved. That can only be said only after you have got histological confirmation that both gonads are present in the same individual. And the last group is 46XX, 46XY chimerism, also leads to ovotesticular DSD. So from this point onwards, you should forget all older terminologies such as female pseudohermaphrodite, male pseudohermaphrodite, true hermaphrodite, intersex. Please forget about all that. These terminologies don't exist anymore. So atypical genitalia look like this. So you have got Andrea Prader staging. This lady, probably 30, 35 years ago, maybe more, 40 years ago, drew these wonderful diagrams. On your left-hand side, the first figure shows near normal female genitals with mild clitoral hypertrophy. And the sixth figure is near normal male genitals with underdeveloped scrotum. So you can have any of this stage. And please remember, as the level of androgen exposure increases, so does the staging's number. So if you have got very little virilization, very little androgen exposure, you get stage that is shown in the first figure. If you have massive virilization, you get something very close to a normal boy. So whenever you discuss a case of disorder of sexual development, we do expect you to tell about the length of the genital tubercle. Now see, in a case of DSD, the new directive is not to use the terminology either clitoris or penis, but you should use the terminology genital tubercle for both in atypical genitalia, and then you measure the length as well as the width of the structure and mention it when you present the case. That will definitely score you more points in your examinations. So the first one, 46XX-DST. So a genetic female who gets virilized. So there is androgen excess. From somewhere, male hormones are coming in excess. So you then have the commonest condition as congenital adrenal hyperplasia. Now this is hyper. Or you can have fetoplacental aromatase deficiency, maternal drugs, disorders of gonadal development, and others. I have already enlisted these conditions, so I won't go through them again. I would now move on to virilized female, congenital adrenal hyperplasia, commonest cause. I'm going to take you through a little bit of embryology and physiology of the adrenal gland so you understand this better. Now on your screen, what you see here is the adrenal gland. In the center is the medulla. We are not going to talk about the medulla. We are talking about the adrenal cortical disease. And in that you have three zones: zona glomerulosa, zona fasciculata, zona reticularis. Glomerulosa is the outer one that produces aldosterone. Aldosterone is the mineralocorticoid, or the hormone that controls your sodium potassium. Zona fasciculata, the intermediate zone, produces cortisol. Cortisol is the glucocorticoid. Glucocorticoid is required for the maintenance of sugar. It's a hormone that is required for fright, flight, and fight. And the third zone, zona reticularis, produces androgens. Androgens are testosterone and its precursors, which lead to virilization. So we are going to talk about these three main hormonal lines: aldosterone, mineralocorticoid; cortisol, glucocorticoid; androgens, testosterone or virilizing agents. Now, as you know, there is a feedback mechanism mainly between cortisol and pituitary, which produces ACTH, adrenocorticotropic hormone, or also known as corticotropin. And the hypothalamus controls that hormone by CRH, or corticotropin releasing hormone. And there is a negative feedback from cortisol at both ends. So in a disorder in which cortisol is deficient or low, the CRH and ACTH become high and they push the other pathways more. So what you're seeing here is a simplified, I'm saying simplified although it looks complex, a simplified pathway of three major hormones produced by the cortex, as I mentioned: aldosterone, cortisol, and testosterone. What I want you to look at is on the third step of the aldosterone and cortisol pathway is the 21 hydroxylase enzyme, the 21OH. That is the commonest enzyme to be deficient in congenital adrenal hyperplasia. So this is an autosomal recessive disorder of cortisol biosynthesis. It is produced by deficiency of enzymes. And then because you cannot produce cortisol and ACTH is flogging you, it's driving the other two hormones, you can't even sometimes produce enough mineralocorticoids. So you end up producing a whole lot of testosterone because that's the only pathway that is working, and that virilizes the female. That virilizes the female. You have reduced cortisol, increased ACTH, increased testosterone, and also therefore the gland looks bigger. So although it's a gland that is underfunctioning, actually it is deficiency of certain hormones. So congenital adrenal hyperplasia is kind of a misnomer where only one hormone is hyperplastic, that is your testosterone, and other two are actually deficient. So these four common deficiencies, but for pediatric residents, I think you only remember the 21 hydroxylase deficiency, and also remember there are three uncommon disorders called the 11 beta hydroxylase, 3 beta, and 17 alpha, and a star protein. Hardly ever in your examination you would, or in clinical practice, most people would have seen them. But 21 hydroxylase, we all as pediatricians, sometimes in our life, will see it. So you have two steroid 21 hydroxylase genes, CYP21 and 21P. CYP21P is the 98% homologous but pseudo gene, leading to many mutations, several mutations, and every year you will get new mutations in this gene, all lead to 21 hydroxylase deficiency. So there are three clinical types that you should know: salt westers, simple virilizers, and non-classic. So babies who are salt westers lose sodium and their potassium rises, and they come in a condition called Addisonian crises. Simple virilizers, their mineralocorticoid axis is relatively spared, so they are only cortisol deficient, and therefore they do not come with Addisonian crisis. They often get missed in case of boys. In case of girls, they will be picked because of atypical genitalia. So simple virilizers, they do not wear salt, but they have high androgens. So they will develop either atypical genitalia if they are girls, and in boys at around 2 to 4 years, they will come with pseudo-precocious puberty. And there is a rare variant called non-classical or cryptic, where what you have is only biochemical abnormalities exist, and they often come as polycystic ovary syndrome in adolescent girls. Now, I think I have already explained to you this, so I'll go on to this flow chart. This is just the same which I showed you earlier as normal, and I have shown you here only up to the third step which I was mentioning. So you have 21 hydroxylase deficiency here. So what is happening is that from cholesterol, your cortisol is blocked. Your mineralocorticoid pathway is blocked. From the 17-hydroxyprogesterone on your glucocorticoid pathway, your cortisol is blocked. So the entire pathway is now flowing rightwards. So instead of flowing downwards, as these two channels are blocked, your whole precursors are flowing rightward into the androgen pathway, and there is excess of androgen. So excess of androgen, deficiency of glucocorticoid, mineralocorticoid because of the enzyme block. Usually this enzyme block is not complete but partial, and therefore you get varying severity of clinical manifestations. So in a girl, you get masculinized or virilized external genitalia, clitoral hypertrophy or prominent genital tubercle, urogenital sinus, or you may have a completely normal looking boy with cryptorchidism. But internal organs are always females because there is no anti-Mullerian hormone in these babies. That's just a revision of the Prader staging of the atypical genitalia. In case of males, they appear normal at birth and they are very difficult to pick up. Salt westers deteriorate very quickly, and usually within the second or third week, they would come with hyponatremia, hyperkalemia, hypoglycemia, and almost a shock-like state. And non-salt westers, however, get missed, and they would only come back to you as pseudo-precocious puberty, which is isosexual. Isosexual pseudo-precocity in boys. So in Addisonian crisis, what happens is babies vomit, they're dehydrated, they may have diarrhea, they fail to thrive, they don't gain weight, they get hypoglycemia, they're hyperpigmented. The pigmentation is high because the ACTH is high. Remember, in humans, melanocyte stimulating hormone is not the hormone that makes you dark. It is the ACTH. So whenever ACTH is high, pigmentation occurs. There will be increased growth velocity as they grow older, and then you have precocious pubarchy, acne, hirsutism, deep voice, and all signs of virilization. So here is a case of 21 hydroxylase deficiency. Both gonads are not palpable. There is hypospadias underneath the genital tubercle. So moving on, how do you manage these babies? Remember, there is glucocorticoid replacement therapy, which is going to be lifelong. Hydrocortisone is given in a replacement dose of 10 to 15 milligram per meter square per day in 3 to 4 divided doses. And you also give 9-alpha fludrocortisone, or what is also known as Floricort, 0.1 to 0.2 milligram per day. This dose reduces as patients get older, the Floricort, but hydrocortisone increases as per the surface area increases. And in the first 2 years of life, these patients also require sodium supplement orally. This is very important. If you do not give sodium supplement, you cannot control the ACTH, or you cannot control devirilization. It's paramount that you give oral sodium replacement in the form of simple salt, 2 milliequivalent per kg per day, or in simple words, in newborns, it will be 1 to 2 gram, which is your, when you tell it to a patient, tell that they have a typical spice spoon in Indian kitchens. So a spice spoon flat is 1 gram, a spice spoon which is fully filled is 2 grams. So they should add it to boiled and cooled water and then give it to the baby in divided dosages. Now, stress dosing. This is something you must know. Whenever a baby with congenital adrenal hyperplasia is sick or unwell, then you should increase the dose orally 2 to 3 times for 2 to 4 days. Whenever they are undergoing surgery, they require much higher dose, 5 to 10 times normal for 48 hours, which is given as injectable dose of hydrocortisone 25 to 50 milligram per kilogram per day. I'm sorry, 25 to 50 milligram or 100 milligram per meter square per day based on the child's surface area, IV or IM. Surgical treatment is best deferred until the child is older, and people should not rush into surgical treatment of atypical genitalia because it is something that has been highly debated, and many patients will actually sue doctors in the court of law for mutilating their genitals. So I think we all have to be very wary and very careful about early surgery in these patients. These are the rare types of CAH. The first one is the common, only remember that. And there are 2 conditions in which you get hypertension. They are 11 beta hydroxylase deficiency and 17 alpha hydroxylase deficiency. Only condition that under-virilizes a 46XY male in CAH is 17 alpha. 17 alpha. So under-virilized male in CAH is 17 alpha who are hypertensive. Their rare form, you may forget them. These are the cartoons of where the enzymatic deficiency is. We can skip these slides in the interest of time. But primarily in this, your 11 hydroxylase is deficient, so you produce a lot of mineralocorticoids. 11-deoxycorticosterone is a potent mineralocorticoid, so you become hypertensive. But 11-deoxycortisol is not a good glucocorticoid, so you still need cortisol replacement. And in 3-beta, it's a high defect, so you have under-virilized males as well as females. 17-alpha under-virilizes a male and leads to hypertension. So practical approach to DSD, this is a simple algorithm that shows you how to go about it. So step 1, unlike in the past, once you have palpated the gonads, you look for the presence of Y chromosome. So first check by doing a rapid SRY test, which comes back in most laboratories in 72 hours. If you have facilities to do MLPA, then it comes back in 2 hours. So once you have got the Y chromosome, if the Y chromosome is not there, do 17-hydroxyprogesterone. If 17-hydroxyprogesterone is high, then you know it is congenital adrenal hyperplasia. If Y chromosome is not there, or you get a mixed chromosomal structure, then in 46XY palpable gonads, you have undervirilized male. So you know it is testosterone biosynthetic defect or androgen insensitivity syndrome. If you have got low dihydrotestosterone after doing a stimulation test, you know it's 5-alpha reductase. However, if your testosterone is low and your precursors are high, it's testosterone biosynthetic defect or defective testicular differentiation. If you have got a mixed chromosomal structure such as 46XY, 46XOXY, then you have got a condition called mixed gonadal dysgenesis. So you can get mixed gonadal dysgenesis. It's called mixed because there is a mixed chromosomal structure and you have dysgenic gonads. Now, I think we are running a little late, so I'll go through 2 cases only. This is a 15 days old full-term baby who has failure to thrive. You can see the clinical picture of the genitals. It's atypical genitalia. Baby is vomiting, is irritable, poor feeding. Gonads show perineal hypospadias, incompletely developed scrotum. There is a genital tubercle. There are no palpable gonads, and you can obviously see a hyperpigmented baby whose scrawny, there is no fat under the skin. This baby is failing to thrive. The sodium is 123, potassium is 7.1, 17-hydroxyprogesterone is 20 nanogram per ml. Testosterone is very high. It's almost in the adult normal range. Cortisol is 10 microgram per DL, which is normal. ACTH is extremely high. SRY is not detected and karyotype is 46XX. So let us fit it in the algorithm that I showed you. No palpable gonads, Y chromosome absent, 17 OHP high, congenital adrenal hyperplasia. Very straightforward. If you hang on to this algorithm, life is easy. Another case, 4-month-old baby, no palpable gonad, genital tubercle, underdeveloped scrotum, no hyperpigmentation, perineal hypospadias with large single opening. Sodium potassium normal, 17 OHP normal, Y fish positive. So no palpable gonad, but Y fish positive. Basal testosterone is normal, LH-FSH are normal. We did a HCG stimulation test, which shows that the testo-dihydrotestosterone ratio is very high. So let's go back to our algorithm and see. At least one palpable gonad, no. We had no palpable gonad, but Y chromosome present. So we go on to the left side of your algorithm and I have colored it blue. So 46XY, undervirilized male, testosterone to dihydrotestosterone ratio is high. Your DHT is low, your ratio is high. So what you have in this patient is a condition called 5-alpha reductase. So undervirilized 46XY male, 5-alpha reductase deficiency. Similar case, 1-month-old baby, you see a genital tubercle, right side well-developed testes and scrotum, left side something like a labioscrotal fold, but no gonad palpable, well-thriving baby, SRY PCR positive for Y, testosterone normal for a male baby, 17 OHP normal. USG shows a unicornuate uterus and there is an ovary on the left side. Karyotype back after 3 days says 45XO, 46XY. So this is mixed gonadal dysgenesis, or what is also known now as sex chromosome DSD. So you see at least one palpable gonad, yes, 46XY, 45XO, karyotype, mixed gonadal dysgenesis. So I'm now going to move on to congenital hypothyroidism. So these are the babies, unfortunate ones, who were diagnosed late. Very, very unfortunate. Look at the baby on the left side. This is a 3-year-old who is completely mentally subnormal. Large tongue. The one on the right side is a 6-month-old baby, developmentally delayed, large tongue, hypotonia, and a malformed ear. Worse even, these two are 6-year-olds. They are completely mentally subnormal. We do not want to see these pictures in 2020. We must diagnose these babies at birth by doing universal thyroid screening, which costs less than 200 rupees. So please, 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 all those of you who are in trainee or who are young pediatricians or pediatrician practicing, for every single baby born, please do a thyroid function test. Do not depend on your clinical judgment. Do not take mother's thyroid history into consideration. There is nothing like high risk screening. Every single baby who is born in this country must be tested with a TSH. So this is just a reminder of the hypothalamo pituitary thyroid axis. You have got hypothalamus producing TRH, which is thyrotropin releasing hormone. Pituitary produces TSH or thyrotropin, and thyroid gland produces T4 and T3. Most of your T3 gets converted. T4 gets converted into T3, which is a metabolically active hormone in the periphery. And there is a feedback at both hypothalamus and pituitary level. So primary hypothyroidism. Primary means thyroid gland is at fault. So what you have is a low T3, low T4, low free T4, low free T3. So productions of the thyroid gland as well as peripherally converted thyroid hormone are low. And because the pituitary is getting no feedback, the TSH is high. So high TSH, low T3, T4, primary hypothyroidism, defective thyroid gland. Exactly converse of this, high T3, high T4, high free hormones. And because there is excessive hormone, the feedback is too much, the TSH is suppressed. So you have primary hyperthyroidism, or what is, if clinically the patient has symptoms, you can also call it thyrotoxicosis. But remember, hyperthyroidism is a biochemical diagnosis, thyrotoxicosis is a clinical diagnosis. Then you have secondary hypothyroidism, where it's a pituitary or a hypothalamic defect. And what you get is the pituitary or the hypothalamus are not doing their job properly. So you have got a low TSH as well as a low T4, low T3, low free T4, low free T3. So everything is low. The boss is not working, the subordinate is not working. This is secondary hypothyroidism. Now, the converse of the primary hyperthyroidism, you can have secondary hypothyroidism. So, what you actually have is a defect in the pituitary and hypothalamus, which fails to either recognize your circulating thyroid hormone, and therefore you have a TSH which is high. It doesn't recognize the high hormones. It keeps producing more TSH, leading to secondary hyperthyroidism. This condition is also known as thyroid hormone resistance. Just to put it all together, when your TSH is high and you have got low free T3, low total T3, low free T4, low total T4, you have primary hypothyroidism. When you have low TSH, high thyroid hormone, it's primary hyperthyroidism. When you have got low TSH, low thyroid hormones, it's secondary or tertiary hypothyroidism. And when you have both, you have got secondary hyperthyroidism, a TSH producing pituitary tumor, or thyroid hormone resistance. See, the last condition which I have shown you, you will probably never see in your life. But as pediatric endocrinologists and endocrinologists, we do end up seeing it sometimes. So for you, first three conditions are important. Just remember the first three. So this is the same thing I have put in a tabular format. We will be showing these slides right now, but I'm sure moderators are going to share this presentation with you so you can have time to study them at your leisure. So cord blood TSH is always high. Remember, whenever you do cord blood TSH, values up to 30, 35 are normal. So Avoid checking thyroid function test between day 1 and day 3. When cord blood is used for screening, because it is done in countries like India, where you see the baby only for a very short while in the hospital, then you have to have your own norms established, as well as you need to take your cutoff from the local place, but generally speaking, they're much higher. They're 30-35 milliIU per ml, whereas normally you would take 10 milliIU per ml as cutoff. So in the first few months of life, TSH up to 10 can be normal, provided that your free T3 and free T4 are in the upper normal range. So let me show you this in a nice little diagrammatic way. What you're seeing here is on your x-axis is the day of life, from birth to a month. On your y-axis is the level of hormones. So the yellow graph is actually showing you the T4, and the pink graph is showing you the TSH. Now, if you take blood sample here at birth, what you get is marginally elevated TSH, which may be anything between 10 to 30, and you get a normal T4. If you, however, did not think very hard and take it somewhere between few hours of life to 48 hours of life, you are going to get very high TSH and high T4. That's the physiological surge that you're catching on to. If you take it after 72 hours, which is what the normal practice in most neonatal care unit is, you will get marginally high TSH and a high T4. And when you take it after 3 weeks, you get normal TSH, normal T4. So if you understand this physiology of hormones properly, it's much easier to understand neonatal thyroid function test because it is dependent on the day of life. Now you have got various types of congenital hypothyroidism. Primary thyroid disease is seen in more than 97% cases, which is agenesis, dysgenesis, ectopia, or dyshormonogenesis. You have a high TSH, low thyroid hormones. Sometimes you get secondary, 1 to 3% cases, everything is low. T3 low, T4 low, TSH low, or low normal. And then there is a condition called transient hypothyroidism, which also we need to treat. Now, congenital hypothyroidism, this is another baby picked up at 3 months. It's already too late, brain damage has occurred. The IQ will be subnormal. We do not want this to happen anymore. These are the signs and symptoms of congenital hypothyroidism. There used to be something called Apgar score of congenital hypothyroidism. To my mind, it is all unnecessary. It doesn't help us in any way. Picking up congenital hypothyroidism so late is guaranteed mental retardation. So although you should know these symptoms and signs, in real life, I think we all should strive to do neonatal thyroid screening programs. So none of these signs are reliable, and we must universally screen all babies for congenital hypothyroidism. Cord blood or serum after 72 hours can be used. If you use cord blood, then the cutoff is higher. You must always confirm your diagnosis with free T4 and TSH values beyond 7 days of life, but do not delay it beyond 2 weeks of life, because then the brain damage will start settling in. With every passing week, in delaying your diagnosis, the IQ of your baby is going down by 5 to 10 points. So please screen on time, follow it properly, call these patients back, treat them effectively. After you have screened, if you want a definitive diagnosis or a pathological diagnosis, a thyroid ultrasound and a technetium scan is done. And in some babies, you can even do maternal antibodies if there is a maternal history of maternal hypothyroidism. Now, here is a technetium scan. You see absolutely nothing in the thyroid gland area. So no signs in the region of the thyroid gland. That is thyroid agenesis, absent thyroid gland. Now, there's a condition called hypothyroxinemia of prematurity, which neonatologists are very well aware of. This is seen in preterm babies and sick term infants. You have a low T4 and T3, and sometimes even your TSH is low, but they recover spontaneously, and thyroxin replacement is not recommended in these patients. Transient primary hypothyroidism, however, where your TSH is high and your T4 is low, requires treatment. It may last for weeks to months, and it is caused by maternal antithyroid antibodies, maternal medications, maternal iodide exposure, and I have seen it happening with something as trivial as vaginal iodide containing douches. Even that leads to sometimes transient neonatal hypothyroidism, or it can be idiopathic. But remember, it requires treatment with thyroxine, unlike your transient hypothyroxinemia of prematurity. This condition warrants treatment. We need to continue treatment until they're 18 months. If they're very well, very low dose, TSH suppressed, you can take it off at 18 months or at 3 years, depending on your clinical judgment and the progress of the patient. But it should immediately be followed within 3 weeks of repeat thyroid function to make sure that it was transient and not permanent. These are the replacement doses that you use. For young children, the dosages are higher. They're 10 to 15 microgram per kilo per day. As the age advances, the dose comes down. Or beyond 1 year, you can simply remember 100 microgram per meter square per day. Remember, thyroxin is given as a single daily early morning fasting dose. So as soon as the baby wakes up, give thyroxin. Crush it and give it. There is no liquid formulation available. So even in newborns, you can crush the thyroid tablet, put it in mother's milk and give it first thing in the morning. As the child gets older, try to maintain a gap of half an hour between the medication and whatever the baby feeds. As a practical point, L-troxin, levothyroxine, which comes as L-troxin, is far easier to crush and give to young babies as compared to all other brands. So how do you monitor these babies? You do thyroid function every 2 to 3 monthly until they're 3 years of age, then 6 monthly. And once they're big children, you can do it yearly. You must monitor growth very regularly on a growth chart. And then you can do it 6 monthly thereafter until they're mature. And bone age is done once a year in these children. TSH alone strategy is going to miss some babies, some rare form of hypothyroidism, such as the secondary hypothyroidism, and some babies who are treated may be missed. So I conclude there, and this is just a joke, that a lecture is a transfer of information from one's laptop to many cell phones without any impact on the gray matter. But looking at the number of people who have been listening, I am impressed, and I hope that you have done a better job than this. Thank you.
Thank you so much, and a lot of questions too. But it was very crystal clear. The presentation was very clear. But obviously, the more clear it is, the more doubts there are.
Yes, that's
so
true.
some of the things which have come up is regarding the diagnosis of DSD.
Yes.
Is there any clinical way to diagnose? Because we know that Y chromosome analysis will take time in most of the units.
Yeah.
But is there any simple clinical clues?
Simple clinical clue would be, if both gonads are palpable, almost always you are looking at a 46XY under-virilized male. If no gonads are palpable and you do a quick ultrasound or an MRI and you cannot find any testes and you find ovaries, then it's a 46XX virilized female. However, if you find only one gonad, then you have to wait. Then there is no clinical way of actually establishing a diagnosis.
Okay, sir. The second question most of the people is, what is the cutoff for 17 OHP? Because we do a lot of screening of 17 OHP. When do we take it as abnormal?
Yeah, very few places in India are doing screening for 21 hydroxylase deficiency because screening is extremely unreliable. In India, there is only one study till date where Rama Ramaddevi actually produced certain norms, and the cutoff that she has given for screening is 20 nanogram per DL. 20 nanogram per ml. So anybody with a 17 OHP above 20 nanogram per ml should be reconfirmed beyond day 7 of life.
So when do you do a ACTH stimulation test? Do we do any time or?
Yes, we regularly do ACTH stimulation tests in our practice as pediatric endocrinologists. One is to diagnose non-classical congenital adrenal hyperplasia. And we also do them a lot in patients who have congenital adrenal hypoplasia, or secondary hypoadrenalism caused by pituitary disorders. These are the situations in which you do a ACTH stimulation test.
Sir, after ruling out CAH, which are the most common DSDs which you have seen?
After CAH, the second commonest DSD that we see is androgen insensitivity syndromes and 5-alpha reductase and testosterone biosynthetic defect.
There was some question on in preterms, how do you differentiate a DSD from prematurity or incomplete gonadal development?
Yes, indeed. It's a very relevant and a very common question. Let us go by the gender. In females who are preterm, mild clitoral prominence is very, very common, especially because they have very less subcutaneous fat and their labia majora are underdeveloped. So often it's an alarming appearance of the genitals, but what is important to understand is if you measure the actual clitoral length and if it is less than 9 millimeters, you can be almost certain that it is not virilization. And if no gonads are palpable and a quick ultrasound can show you the uterus, you are pretty sure. However, if you or your seniors decide to do 17-hydroxyprogesterone on such babies, you have to be very careful because 17-OHP is spuriously elevated in preterm babies. And you also need other parameters such as testosterone and ACTH to confirm your diagnosis in these tricky situations. In case of term babies, females, simple clinical test is that if the clitoris looks slightly prominent, then you straighten the thighs and get them together. When the thighs are straightened and they're together, you should not be able to visualize any clitoral structure. If you do, then you're justified in investigating.
So the other thing is, while you're treating CAH, like in congenital hypothyroidism, are there any particular values we look at for sodium, potassium, for 17-OHP monitoring? So how do we know that whether steroid as well as your
whether it is
as well as the androgen is excess or normal?
Correct. Once you have started the patient with oral hydrocortisone and fluoricort, then you monitor it by doing 17-hydroxyprogesterone, cortisol, and ACTH. Now, in many situations in India, this becomes too expensive. So people often end up doing only 17-hydroxyprogesterone. What is important to remember is that 17-OHP is a very volatile molecule, and despite your adequate treatment, it may be elevated. So my practice has actually been not to measure 17-OHP, but to measure testosterone. And if your testosterone is well suppressed, in a single test, you know the adequacy of your replacement. Two other factors help. Number one is if the growth velocity, especially in terms of length, is adequate, that means that you are giving enough. If the growth velocity is low, that means you are over treating. If the growth velocity is high, that means you are under treating. It's a very useful way to plot the baby on a growth chart and to see in which direction the growth parameters are going. So clinically, growth monitoring and biochemically testosterone level in both genders up to childhood. Once they get into puberty, for boys, you also need to look at other parameters, but that's not really the point of discussion for today.
How frequently monitor, sir, for testosterone?
For testosterone, in the first year, I would do it once in 2 to 3 months. Thereafter, I would do it once in 4 to 6 months. And once they're in puberty, sometimes you have to again go back to more frequent monitoring, especially in girl children.
So now moving on to hypothyroidism, sir.
Yes.
Now, when do you do free T3 and free T4?
Right. See, there was a time when these free hormone levels were very expensive. So we reserved them for certain situations where total T3, T4 were not conclusive. But In simple words, I would say in pediatric practice today, the difference between free T4 and total T4 is so less in terms of cost that you're probably better off asking free T4 and TSH rather than total T3, T4, TSH. But if it is not available in certain situations, that can happen. I would recommend doing free T4 in situations where the patient is already on treatment, number one. Second is, if you are suspecting central hypothyroidism, you should always do free hormones. And third is, if you have got a patient who has had a brain tumor who has been operated, there you always ask for free hormones. And of course, in thyrotoxicosis. These four situations in which you would ask for free T4 rather than total T3, T4.
The other thing about the dilution, L-troxin is what you suggested.
Yes.
What is the ratio we have to dilute in milk or in water?
Hardly any specific dilution. You just crush it, put if there's a spoonful of breast milk, it nicely dissolves and the baby can have it actually. There's no specific. Lot of pediatric endocrinologists unnecessarily ask patients to put it in 5 ml of water and give 2.5 out of that, etc. Not required. Today in India, you get strengths from 12.5 microgram to 150 microgram. So no dilution is required. Just a spoonful of water or milk is all that is required.
The other thing is now people are moving from day 3 to day 1, day 2 screening of hypothyroidism because most babies are out of the hospital within 24 hours. Are there any R-specific nomograms, or if you're doing early, should we do both?
Well, if you are in a hurry to discharge the baby, the best way to screen is cord blood. Don't screen beyond cord blood. Then straight away do it on day 3. These values in between, as I showed you the physiological surge, they are so erratic that they're always going to mislead you. So people who are working in a hospital where there is an early discharge policy, which is what it is in most hospitals, we strongly recommend cord blood TSH.
So if one is monitoring by 17 OHP after treatment, what is the cutoff 17 OHP one aims when you're giving steroid?
Right. I mean, sorry, when you're giving steroid?
Yes, sir. For 17 OHP,
okay.
when you're giving steroid, what is the cutoff?
So when a patient is on treatment, you would like the 17 OHP to be under 7 nanogram per ml. And if you are doing testosterone level, it should be under 12 nanogram per ml.
Are there any medications which affect this interpretation of screening for hypothyroidism?
Hypothyroidism and medications, not really. Not really. Maternal antithyroid medication can affect it, but in India, the policy is allowing mothers to breastfeed because the advantages of breastfeeding grossly outweigh the disadvantages. So no, I wouldn't think of any medication which would alter the TSH and T4 level very much. No.
So one more question is are there any clues to say it is transient hypothyroidism versus congenital hypothyroidism?
Yes. If the dose required is extremely low, like for example, if you have a baby who is say weighing 5 kilos, then you expect the dose to be about 50 micrograms per day. But if your dose requirement is something like 12.5 or say 17.5, something very minor, then there is a chance that it may be transient, but it is not guaranteed really, not until you stop it once and see.
Maternal hypothyroidism and baby having hypothyroidism, how common is it? When do we screen?
Yeah, less than 1% of moms who are hypothyroid actually give birth to a baby who is hypothyroid. So your chance of finding a baby in a hypothyroid mom is actually less than finding it in general population. So there is no role of selective thyroid screening. We actually screen every single baby.
So when should we refer a baby with DSD as well as a baby with hypothyroidism to an endocrinologist?
Well, I think when it comes to DSD, you should really refer every baby. They are much too complicated. Because there is not, the endocrine aspect is the easy aspect. The psychosocial aspect, you need a multidisciplinary team to manage these patients. You need a surgeon who is experienced. You really need a tertiary level care unit to manage every case of DSD. However, there are some pediatricians who are experienced and senior who can manage their own congenital adrenal hyperplasias. I have no issues with that. They do a pretty good job. But again, once a year at least, these patients should be seen by a pediatric endocrinologist. When it comes to managing hypothyroid babies, I think simple primary hypothyroidism, if you're confident that you're keeping the TSH under control, the growth velocity is normal, the development is normal, you can manage at pediatrician's level. But if the values are not fitting in, if the development is not looking right, if baby is not growing well, despite your attempts, the TSH is swinging too much, refer.
Sir, why there is no syrup or drops of L-Throxin or Thyroxin?
It's very unstable in liquid form. The only company which has managed to do a good job of a preparation which is liquid is Germany, but that damn thing is not available anywhere else in the world.
So I think you have already suggested for transient hypothyroidism, we need to check for the stopping is after 3 years, isn't it?
After 3 years, ideally 3 years, unless there is compelling or overwhelming evidence that the dose required is so minuscule that you can take the risk of stopping at 18 months.
The other thing is, what is the time for clitoromegaly, or even up to 7 years, the parents are making decision, do you mean to delay till adolescence, or that is surgical?
You can actually delay it until adolescence. The recent guidelines say that only superficial surgery may be done if there is a social requirement, say kid going to school or something of that sort. But any major surgery where any major genital manipulation is going to take place should be deferred until the child is adolescent, because we have to take into consideration the child's views. Most people with DSD who have had surgery at a younger age, a corrective surgery, a major one, have written to doctors and in fact have sued them in the court of law for having no reason to decide the gender of that particular individual. And I think in this day and age, we all have to be very careful with this. So I would say defer all major surgeries until they are old enough to understand what's happening. But superficial surgeries like clitoral reduction may be undertaken in CAH patients, especially for social reasons.
Are there any cases of subclinical hypothyroidism in children?
Subclinical hypothyroidism is a very dubious diagnosis, and I would strongly recommend a marginally elevated TSH, which is commonly seen in obese children, is not subclinical hypothyroidism. It's peripheral thyroid hormone resistance because of elevated leptin caused by obesity and does not require treatment. So subclinical hypothyroidism in childhood, I don't think exists, and people should really not jump onto that diagnosis at all. In adolescent, perhaps some menstrual irregularities in a girl who is 17, 18, maybe there is some role, but not otherwise.
Thank you so much, sir. I think it has been a vast experience in a short time, and it is really very lucid presentation. A lot of doubts have been answered, and I'm sure we had 420 people coming in today, sir. So it's a huge audience, and I'm sure many would have benefited from this wonderful lecture.
And thank you for giving me the opportunity to get a glimpse of Ambedkar, sir, also.
Thank you, sir. To the attendees, we have a poll now, and after the poll, I will tell you how to register yourself for subsequent webinars. I am launching the poll, so people be ready. You can start doing the poll questions, and then it is from yesterday's presentation. So you can answer and keep scrolling down. You can see the questions and then scroll down, and you can click on the correct answer. Sir, while the poll is going on, thank you so much, and we will post your questions tomorrow. The questions to see the retention of the people.
Okay, I know it's a hard topic. Yes. And Srinivas.
Yes, sir.
On that video, can you just correct that spelling of my name, please?
Okay, sir. I'll do that.
Yeah.
No, the video. Your name is on the first slide, no, sir?
Yes.
So it's going to be the same. So we are not going to change the exactly the slides, and your audio is going to be there, sir.
Right. Okay. Right. So can I stop sharing the screen now?
Yes, sir. You can. So thank you so much, sir. We will follow with the poll and then connect with the audience.
Great. Thank you so much. So shall I log off now?
Yes, sir. You can.
Thank you.
So we'll wait for another 30 seconds and then we'll end the poll. Okay, the poll is over. Let's see the answers first. Mark the wrong statement. I think there is equivocal thing, but the correct answer is cardiac output is mostly increased in newborn by increase in stroke volume is wrong. Newborns depend more on heart rate than stroke volume to increase the cardiac output. Shock is best managed in a newborn by supportive care. So that takes priority over all other things. Unless you take care of supportive care, rest of the things do not work. Most likely to improve with fluid management.